Hi everyone, and welcome to the AcceSex workshop. I'm Tess from Women with Disabilities Victoria, and this is a workshop on disability and reproductive and sexual health. And this is my colleague Zoe Dorothy. But my name is Tess, as you've heard. My pronouns are she and her. I've been working for Women with Disabilities Victoria for about 2.5 years now. I have a social work degree and Cert 4 in training and assessment, and I use my lived experience of cerebral palsy to inform training. And today I'm wearing all black with my hair tied up in a bun, and I use a wheelchair, just as a visual description of myself. Zoe?
Thanks, Tess. Hi, everyone. My name's Zoe Dorothy. I'm the Sexual and Reproductive Health Workforce Development Officer, and AcceSex is my project that I've been working on for the last 2.5 years. My pronouns are she and her. My background is I have a Bachelor of Psychology and a postgraduate diploma in sexology. Yes, that is a real degree. I was born and raised on Wammarai and Wabaka lands in Newcastle and recently moved to Melbourne. And as a visual description of myself, I'm a young-ish white woman, and my hair is tied up, and I've got a green cardigan on today. All right, back to you, Beth.
Thanks, Zoe. So today I'd like to acknowledge the traditional owners of lands and waterways in which we gather here today, and pay my respects to their elders, both past, present and emerging, and anyone here today who identifies as Aboriginal or Torres Strait Islander. And I'd also like to mention the ongoing strength and resilience of Aboriginal women with disabilities, as they are 35 times more likely to be hospitalised due to violence.
So who is Women with Disabilities Victoria? So I know that we've got quite a few people from around Australia joining us today. So Women with Disabilities is a peak organisation for women with disabilities in Victoria, and we are a non-for-profit organisation that's run by and for women with disabilities. And if you'd like to learn more about us, please head to our website.
Yeah, I'm all good now, Zoe. So, and we do this in a number of ways. So we do it through empowering women through our enabling women's programs, or even through our experts by experience programs, where we pay women with disabilities to consult on large projects. We influence policy through influencing stakeholders like the NDIS to make services more gender and disability responsive. And we influence services through doing training, like the training I do in my work, where we train social service organisations or organisations relating to family violence or disability on how to be gender and disability responsive and prevent violence against women with disabilities. Thanks, Zoe.
Great. So here's a little bit of a schedule of what we're aiming for today. So we've got our introduction, which is where we are currently. Then we're going to jump into disability, gender and intersectionality. Then we're going to head into sexual and reproductive health and disability. And then we should be having a break in between accessibility in practice and sexual and reproductive health. I don't know exactly what time that will be, but we're aiming for around 2 o'clock. Then we're going to have a little bit of reflection time and wrap up, and we should be finished by 2:45. If you do need to leave early, we are recording this session, so if you miss out on anything, don't worry. Just you can jump in and check out the recording later, which will be sent out afterwards. And take breaks as needed, and also if you don't, this is being recorded, so if you don't want to appear on the recording, just turn off your camera. But, we like to see your faces, so if you want to keep them on, that's okay too.
Thanks, Zoe. So what are we going to be learning about today? So today we're going to be learning about discrimination and violence experienced by women with disabilities. We're going to address stereotypes, negative attitudes about women with disability, and sexual and reproductive health. We're going to learn how to make your programs and services more inclusive and approachable for women with disabilities. And we're going to learn to address the specific sexual and reproductive health needs of women with disabilities in your service.
So something that we wanted to note is that evidence has repeatedly shown for women with disabilities that the biggest barrier to sexual and reproductive health care is the negative attitudes of staff and people around women with disabilities, such as carers and parents, when they enter care settings. And that perpetuating the negative stigmas and attitudes around sex, disability and gender can be conscious or unconscious, but we're all responsible for eliminating all these forms of discrimination and ableism. So that's just something to keep in mind as we go through today. So working with your uncomfortable feelings, if you do have any, hopefully you don't. Some of the topics that we're going to be covering today might be confronting or distressing. Some of your reactions might be not knowing what to do with new information, disbelief, resistance, or even distress over past behaviour. And some ways to manage this are to notice your resistance, to stay present with us here, to be curious, take a break, write down what you're feeling in the moment, speak with peers or co-workers or a manager after our workshop, ask a question, obviously that's a great one. And if it is triggering something around an experience with sexual or family or domestic violence, you can contact 1-800-RESPECT and they can support you either as a survivor of violence or as a professional to talk about how to support people experiencing violence. So, you know, just if you're experiencing any of these uncomfortable feelings as well, you can just notice that resistance and manage it in the moment. If you don't resist it, it can kind of help the feeling pass more quickly. So they're just some things to keep in mind. Don't feel like you can't ask a question in the moment, of course. And we're also going to have some Q&A time at the end. So if you do have a burning question that we haven't answered, there will be some time at the end as well. All right, we're going to jump into our first topic, disability, gender and intersectionality. Over to Bess.
Thanks, Zoe. So as you can see from the slide, there are multiple ways of thinking about disability, and at Women with Disabilities Victoria, we use the self-identification model. So if you identify as having a disability, then you're a person with lived experience of disability, according to WDV. But there are other theoretical models like the social model and the medical model, NDIS, Centrelink have criteria in terms of disability as well. But there is no one definition of disability, as you can see, and the different definitions might stop people from identifying themselves as having a disability. And as you can see, well, hear, touch, whatever, disability is not just physical or visible. It can be intellectual. You can have autism spectrum disorder. You know, you can have dyslexia. You know, a disability is not just a wheelchair like the disability symbol we often see. So what is disability? So like I said before, WDV works on the model where people self-identify as living with a disability, e.g. physical, sensory, intellectual, cognitive, acquired brain injury, or autism spectrum disorder. And the UN Convention on the Rights of Persons with Disabilities include those who have long-term physical, mental, intellectual, or sensory impairments. So disability is an evolving concept that results from the interaction between the person with impairments and their attitudinal and environmental barriers that hinder their full and effective participation in society on an equal basis to others. So the UN definition of disability highlights that disability involves a long-term impairment, and it also says that disability is more than just a person's impairment. Disability is impairment plus the attitudinal barriers that hold people back. So this might be not being welcoming in a service, not being friendly, and looking beyond ramps or elevators in terms of access, and making disability access and inclusion at the forefront of your mind, rather than being like, oh yeah, this person now has a disability, now we'll do something. Like, it should be there always as an ongoing process.
Yeah, definitely. All right, so now I'm going to jump into a couple of different models of disability. And a model is just a way of conceptualizing a point. So we've got the medical model here and the social model, and Tess is going to go through the social model, but I'll start with the medical model first. So under the medical model, disability is a tragedy or something to be overcome. The problem is the individual's impairment and their body. The solution is to fix or cure the impairment to make the individual more normal, quote unquote. Services are delivered in separate institutions. So this is kind of the idea that, you know, people were institutionalized, kept away from society, you know, treated as, you know, that they weren't meant to be a part of normal society. Professionals are considered the experts, and the individual is considered sick, passive, and dependent.
So thanks, Zoe. So the social model of disability is the one that's widely used today, moving on from the medical model, and it sees disability as a natural part of human diversity. And the problem is the environment and the attitudes, like I said in the previous slide. So this is where the structures, policies, and processes come into place, and are quite disabling for us, but as well as your attitude. So even for someone like Carly Finlay, who is a disability advocate, she has facial difference, and she notes in her books that that is a hugely disabling factor for her. And of course, the solution is to make society more accessible and remove stigma and discrimination. Services are delivered within the community and within mainstream services, particularly now within the introduction of the NDIS. Well, it's been going for quite some time now, actually. Professionals are part of a collaborative team, and the individual is an expert in their own experience, and we often self-advocate. Yep. So this is the human rights model, and it kind of extends from the social model in 4 key ways. In that, it embraces impairment, it recognises people with disabilities as experts in all matters that affect their lives. Keyword experts. Yeah. And then that equality does not mean treating everyone the same. And it places accountability on governments to take action as well. So, and this picture is a like a mural, that's how you say it. Yep. A disability pride mural. And disability pride is basically a protest against the medical model, which tells us to be ashamed of having a disability. So disability is kind of an identity, and it's an integral part of who we are, and it's something that influences everything in our lives, but it's not all of who we are. We have many roles in society. We are teachers, doctors, lawyers, sons, daughters, you name it. And we borrowed this movement idea from the queer pride movement as well. So, and it teaches us to love ourselves and our body with having a disability, and to be able to self-identify as being disabled or having a disability allows us a broader connection to a proud disability community as well.
Great. So all of this obviously comes together under this idea of intersectionality. So we've titled this part intersectionality, power and privilege, because intersectionality is more than just identity. So intersectionality is when two or more identities or experiences meet. So in our case, it will be women and disability, so women with a disability. And intersectionality this is the basic definition, is interconnected nature of social categorizations such as race, class, and gender as they apply to any given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. So to be intersectional, as we are, we like to model for other people, is to see the difference and also the unique experiences that are created by the intersection of being a woman and having a disability. And it's to see the value and of the expertise that brings to that different perspective brings. It also means that we're responding to multiple forms of oppression, which is discrimination, basically. So we understand that we can't end gendered violence without also fighting racism, capitalism, poverty, all the different forms of discrimination to help women with disability to fully participate in life. And so something that is often forgotten, I think, particularly when we work in women's health services or in a specific health service, is that disability is just one identity of many, right? But disability exists inside all groups. So just like there is a queer community and that all the variety that is in a queer community, disability is also within that community. You know, within migrant communities, disability is just also an additional experience to being a migrant. So it's really important to, if you're working with a specific group, that you're also thinking about disability as another aspect of a particular group that you're working with. And it just means that the system or the service that you're delivering is going to be more inclusive and working towards meeting the needs of everyone who's accessing that service. All right, let's do some stats. So nearly 1 in 5 Victorian women and girls have a disability.
Nearly 1 in 3 Aboriginal and Torres Strait Islander people report living with a disability.
In Australia, 45% of people with disabilities live in poverty or near poverty, a situation that has worsened in the last 20 years.
The rate of disability for Victoria's culturally and linguistically diverse population is 22% higher than that of the general population. And can I ask people to mute themselves if they're not speaking? Thank you. Zoe?
Yep. So women with a disability are less likely to be employed than men with a disability.
Women with a disability
I think you're number 7.
High rates of disability and long-term illness in the LGBTQA+ community. This is 23% versus 15% in the general population.
Trans men and women are reported even higher rates of disability than the wider LGBTI community.
And LGBTQA+ people with disability were significantly more likely to be unemployed. That's 20% versus 4%, and have to experience discrimination, harassment, and abuse, 13% higher rate than in the past year than those without a disability.
Yeah, so we can see from those statistics the intersections that come with disability. And we're going to now watch a video from Jackie Brown, who is a disabled advocate. Their pronouns are she, they. And they're an activist and writer from Melbourne, so you might have seen them around. And this video is talking about the intersection between sex, queerness, disability, and what that all kind of comes together and means when thinking about disability and identity. So I'm just going to play this video. Give me a second. All right, so sit back and we're going to be watching this for about 8 minutes.
To me, I guess it means pleasure, and I guess it can also mean pain if you want to play with that. But I think fundamentally it means pleasure and it means connection to my body. And I think particularly for people with disabilities, we're taught to internalize a lot of shame around our bodies and kind of want a normal experience. And so for me, finding ways to get in touch with my body, whether that be masturbation, whether that be sex with other people, and actually feel what it actually feels like and actually allow my body to experience that and react the ways it wants to react and move the ways it wants to move and experience pleasure was actually a pretty radical thing, because learning how to connect with something that you've been taught to feel so disconnected from is a bit of a process, and it's kind of an ongoing one. And I think particularly for women with disabilities, it's really important that we develop a language around our bodies and our desires and our sexualities, because often we're not given sex education, we're not taught about consent, all these kind of really important things. And if we are told anything about our bodies, it's all from this space of you're flawed, or you've got these things wrong with you that you're going to have to manage to get anyone to want to be intimate with you, and you should just be grateful for whatever you can kind of get. I got a lot of that messaging from a bunch of different people in my life growing up, and so people really aren't given a perspective of their bodies or a language of their bodies that's strength-based, that's pleasure-based, that looks at what do you want to do with your body? What feels good? How can you explore that? I think sexuality and our sexual and gendered expression as people with disabilities is the area of our biggest oppression. And yet it's often not focused on at all. I think all these structural issues about making transport more accessible, making buildings more accessible, making employment more available for people with disabilities, they're really, really, really important for changing what the world looks like for us and giving us equality. But so too are our intimate relationships. They're super important as well. You know, our capacity to feel love and connected and proud of who we are is just as important as whether or not we can get on the local bus or the tram or have access into a building. So this idea that, you know, we can be loved, we're worthy of love, we can be desired, and desired in a way that doesn't fetishize us, that doesn't look at the chair and presume that therefore I'm going to be passive in bed because, of course, you know, people with disabilities are just going to be grateful for whatever they can get, and that therefore they're going to behave in particular ways if you sleep with them. That those kind of ideas are still pretty prevalent, I think. But I guess as a young person, I'd grown up with quite a lot of medical intervention on my body for years and years. And I'd really internalized this idea that there was something inherently wrong with me, that I needed to be fixed or cured, and I should kind of spend my life hoping for a normal body. And so when I discovered the social model of disability that said, hey, you're not wrong, you're not the problem. The issue is a society which has failed to include people like you, and, you know, stereotypes and all these kind of ways of looking at disability which don't allow you to be a whole, complex, nuanced person. Discovering these ideas was really, really amazing because it helped me reframe the issues from me being the problem to the way in which society was structured was the issue. And then I could kind of go, well, actually, if it's been created this way, so too can it be changed. I think access is a really big issue, particularly in the queer community, but also everywhere. So many spaces are inaccessible. So people just aren't used to seeing people with disabilities in a nightclub having a pash on a Saturday night, or, you know, at a community event, or, you know, being part of the community, just being out and living lives like everyone else. And so when I find my way into those spaces, people are surprised. People are still like I've been in a gay bar looking like this. Like, I think I flagged Dyke pretty hard. And I've had like a woman come up to me equally as Dykey and go, honey, do you know you're in a gay bar? Like, I must have kind of wheeled in there and got a bit confused and was just going, where am I? There's these assumptions that people with disabilities should just stay at home and live sad, miserable lives where we kind of sit on the couch all day and wish we could be normal. These kind of ideas need to start to be really challenged and changed. And one of the key ways that we see that is if we make society more accessible, but also if we see people with disabilities in the media, you know, talking about their lives and their identities and themselves in ways that counter these narratives of disability as tragedy or disability as inspiration. Because I think for me as a young person growing up, there really was nothing. Like, I had no idea of what my future would look like. I was pretty sure that I was just going to die, even though my disability isn't terminal at all, because I had no concept of who I could become, of, you know, if I could have a job, what that might look like, that I could have a partner, that I could aspire to have kids, all those kind of things just weren't modeled to me at all. Yeah, so my journey with sexuality. I guess, yeah, it's been a bit of a long one. And when I do things like this, I sometimes think, who do I want to speak to? Like, what is my primary audience or my primary person if I could put a message out there? And I guess I think back to that 16-year-old in the small country town feeling shit about herself, and wondering if she had a future and what that looked like. And so even though I feel miles away from that now, thankfully, I still don't want to pretend like it's been easy and like it hasn't been a journey to get here, because I think that wouldn't speak to her. She would go, I don't believe you. Finding my own voice and finding my own narrative and knowing what that is and knowing what my politics are, is an act of pride in a world that tells me that I shouldn't have them, or that I'm wrong, or that, you know, I'm viewing things not in the right way. So yeah, I think holding on to that and going, no, I'm valuable and the ways that I see things are important. And then on a personal level, even though the political is personal, on a bodily personal level, learning how to inhabit my body is an act of pride and resilience. Learning how to feel what it feels like and move in the way that it wants to move, and no longer being ashamed of that, but being proud of that. Oh, I love so many things about my body now, and as a young person, I never thought I would say that. Like, yeah, it's really sad to reflect on how I used to feel. Yeah, I used to kind of think I must be the most monstrous person ever, and, you know, no one could want this body. But these days, a lot of people have wanted this body, and I love this body. I love that it's different to most other bodies. I love that it moves differently. I love that my emotions are in my body and I can't hide how I'm feeling. Like, my muscles tense up when I get excited, or when I get passionate, or when I get sad. That I show my feelings differently to everyone else. I love that I move through the world differently. I love how I can feel the lean of gutters and the slopes
All right, I'm going to cut Jack's off there. If you'd like to watch the rest of the video, of course, it's available online and it will be in our resources that we send out later. All right. So I hope you really enjoyed that video. We love that video. Everyone seems to love that video. And I think it's really great because it brings together, you know, the idea of sexuality and sexual being and disability and what that kind of means in how you see yourself and the impact of negative attitudes and the, you know, what people are coming to you with. If you haven't had a lived experience of disability, it kind of gives you a really good insight into some of the baggage that's coming along with people. Not that necessarily that's every person's experience, but some of the ideas that people might be coming in to see you with. Okay, we'll jump over to the next slide. Over to you, Tess.
Thanks, Zoe. So I'm wondering if anyone's ever heard of ableism or not, but so I'm gonna just go into this anyway, and then if you have any questions at the end of the slide, feel free to ask. But ableism is discrimination and social prejudice against people with disabilities who are perceived to or who are perceived to have disabilities. And ableism defines people by their disabilities and assumes that disabled people are inferior to the non-disabled. Ableism is a systemic form of oppression that reinforces the wider systems and attitudes in society, and disability stereotypes are used to justify disability discrimination. But also, ableism is not just about individual attitudes, but I'd like to remind you that it's also about systems and systemic discrimination. Like, for example, if a woman was married to a man and she was originally on a disability support pension, if she then married him and he had quite a bit of money, her disability pension would be taken away because the disability pension is means and assets tested, which means that she would be completely financially dependent on him, which when we think about violence is that's really a rife situation for financial violence to occur. But moving on. Okay. So, like I said before, making sure that disability is not an afterthought, and that you're always willing to be welcoming and friendly, and that your violence response services are not inaccessible either. So is there anything else you wanted to add?
No, all good.
Great.
All right, we'll jump to the last slide for this section. I feel like we've jumped through it. So take a moment now to just sit back and listen to this wonderful quote from AJ Withers, who's a disability academic and advocate. And it says, another myth that is firmly upheld is that disabled people are dependent and non-disabled people are independent. No one is actually independent. This is a myth perpetuated by disableism and driven by capitalism. We are all actually interdependent. Chances are, disabled or not, you don't grow all your own food. Chances are you didn't build the car, bike, wheelchair, subway, shoes, or bus that transports you. Chances are you didn't construct your home. Chances are you didn't sew your clothing or make the fabric or thread used to sew it. The difference between the needs that many disabled people have and the needs of people who are not labelled as disabled is non-disabled people have their dependencies normalised. The world has been built to accommodate certain needs and call the people who need those things independent, while other needs are considered exceptional. Each of us relies on others every day. We all rely on one another for support, resources, and to meet our needs. We are all interdependent. This interdependency is not a weakness, rather it is part of our humanity. So I love this quote because it really brings together everything that we've been talking about disability, identity. You know, we kind of have this idea that disability is separate. It's a different experience. If you don't have a lived experience of disability, it's something that, you know, you could never experience. But we know that the way that we move through the world means that we need other people and that our needs are all valid, and that being disabled isn't an additional or special need. So I really love to include that quote there.
Yeah, disability is not exceptional.
No. Do we have anything in the chat, Tess? I haven't actually been checking the chat, so if anyone's been popping anything in there, I'm sorry, I haven't checked in a second. But we've just come to the end of that section. Whoa, skipped ahead of that. So, oh, there's one thing in the chat. Just a comment on Jack.
Yeah.
Thanks, Patty. So what we'll do is we'll jump into the next section. I think we're going pretty well for time. And then we should be having a break at the end of this section. So gather all your mental strength as we head into the section of reproductive health and disability. So it's something that I'd like you to think about as we're moving through this section, is maybe you could think about some of the stereotypes that exist around women with disabilities, sex and disability, or sex and women. And you can drop a couple of them in the chat if you want, or you can just think about them, or you can concentrate on what I'm saying if you don't like to multitask. And just think about how this might impact the way that women with disability move through the world, how they might access sexual and reproductive health care, as we jump into some definitions about sexual and reproductive health. Oops, head again. All right, so what is sexual and reproductive health? So I'm sure you've all heard this definition before from the World Health Organization. So sexual health is a state of physical, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. So, pleasurable, super important. It's often assumed that men have a right to enjoy sex, but women not so much. And for women with disabilities, it's even less likely that their sexual pleasure will be the focus of the healthcare that they receive or the education that they receive. However, pleasure, we can see from this definition, is fundamental to well-being, and we all have a right to access it. And women with disabilities obviously might need some additional information or support to access sexual pleasure. And free of coercion is really important because we know from all the data that's out there that women with disabilities are twice as likely to experience violence during their lives than women without disabilities. So it's really important to emphasize that that is definitely a right, free of coercion, discrimination, and violence. All right, on to the next slide, Tess.
Thanks, Zoe. So, the Convention on the Rights of Persons with Disabilities mentions that we must have access to information and services, live free of violence and coercion, have our privacy in spaces and with our personal information, must focus on eliminating discrimination against people with disabilities in all matters relating to marriage, family, parenthood, and relationships, including the areas of family planning, fertility, and family life. And we must have equal access to sexual and reproductive healthcare programs in the community. But also, this has been based and specifically highlighted by the UN because these rights are so often breached for women with disabilities. And a rights-based approach is what should underpin all of our work across the violence and reproductive health sector. And Zoe has a wonderful example.
Yeah, so I guess this all comes back to the idea that we're fighting for equality, equity, and justice. So there's this idea of reproductive justice, which is specifically around, obviously, sexual and reproductive health. And this focuses on, well, when it comes to justice, it focuses on dismantling systemic oppression, so ableism when it comes to disability. And sorry, I'll start again. Dismantling systemic oppression that reinforces marginalization, inequity, and violence. So this is really important if you don't know the right answer to something, because sometimes it's really hard to have the right answer, and sometimes there isn't a right answer. But if you in your approach, if you're using a rights-based approach, which is, just those things there, that you're going to be able to make the best decision you can in that situation. So just keep that in mind when we're going to have a discussion later on some of the trickier questions around women with disabilities and sexual and reproductive health. Keep in mind just having that rights-based approach. I can see you put a couple of people putting questions in the chat. I'm actually going to be talking about some of those things later, so don't worry, I'm not missing your questions. Don't worry. Tess, back to you on reproductive coercion.
Yes. If you can just give me 1 minute, I'll be with you. So reproductive coercion and violence for women with disabilities. So reproductive coercion is about using power and control to limit women's choices when it comes to reproduction, coercion, and abortion. So women with disabilities experience the same kinds of reproductive coercion from their intimate partners as non-disabled women, but women with disabilities have the additional experience of ableism or disability discrimination based on reproductive coercion and violence. And it's important to note here that perpetrators use our disability against women with disabilities to silence and control us. And this might look like taking a wheel off a wheelchair, or underdosing or overdosing us, or taking away our services in terms of systemic violence as well. So the violence we experience as women with disabilities is often more intense and occurs over a long period of time and often inflicted by multiple perpetrators as well. And thinking back to what Zoe said on intersectionality, so of course, violence against women with disabilities is intersectional, and this means that sexism and ableism combine, or the experience of being a woman and having a disability combine to create a double disadvantage or inequality. And like I said, women with disability can also experience disability-based violence, and may use a woman's disabilities as tactics to abuse them.
I think you already gave an example of that, right?
Yeah, another one is gaslighting, where someone with a mental illness might be like, oh no, but this happened, and then you're using her mental illness against her to suggest that she's lying or to manipulate the situation in a certain way.
Right. Okay, I'm gonna jump to the next.
Sorry, Zoe, if I added an extra example there.
No, that's perfect. So we would usually show this video, which is really, really great and will be in our list of resources, but we don't really have time today. But please check it out. It's a story that is about women with an intellectual disability and accessing sexual and reproductive health information and what power and control kind of looks like in that scenario. So we're just going to jump ahead to the next slide, which is about stereotypes and reproductive coercion and eugenics. So I don't know if many of you know about the idea of eugenics. It comes from this idea, I don't know if you're thinking back to your high school biology, Charles Darwin, natural selection. hopefully I'm getting you in the right mindset there. So he came up with this idea that, you know, fittest was the best. And he was talking about this in terms of the natural world, in terms of animals and things like that. And this idea of, yeah, fitness, who is the fittest to be in society. And people then went, what if we applied this to humans? But, you know, humans are a little bit more complicated than the natural world that's around us. And so this is where eugenics began. And so the main driver behind eugenics is this idea of like fertility control and sterilisation. So that's where sterilisation comes from, this idea that people, you know, who had these undesirable traits, of which disability was considered one of them, or perceived disabilities, which could include being poor, which is not genetic, that they would try and limit their ability to have children. And so it was basically about trying to prevent disabled children from being born, which is obviously not possible. So these are kind of seen, you know, even though people wouldn't say what they're doing today is based in eugenics, it has heavily influenced people's ideas around disability and creates a lot of unconscious bias. So if some of these things come to mind today and you're just like, oh, I didn't realize I had that bias, that's okay. It comes from a historical place. And it's just important to challenge these ideas in yourself and make sure that you're not perpetuating them. So when it comes to sex, women, and disability, there's obviously lots of different stereotypes out there. So assuming that disabled people can't have sex, assuming that they don't want to have sex, that people with disabilities are undesirable, assuming that disabled women can't care for children, that disability is considered a burden and that disabled people don't contribute to society, and that you know, in contrast to the previous stereotype, women with disabilities are also hypersexual, like they want to have sex all the time and can't control themselves. So, you know, stereotypes don't have to be consistent. That's the point. They're not obviously based in logic. So it's really important when we're talking about sex and disability, and I can see from some of your questions there, we can see some of those biases, those stereotypes that are coming into play when it comes to delivering healthcare, when it comes to delivering education to people with disability around sex. And so when it comes to reproductive coercion, we're talking about reproductive coercion that occurs not only within intimate relationships, so reproductive coercion is anything that is trying to influence women's decision around their body and what they want to do around sex and reproduction. So for women with disabilities, they can also experience all the different kinds of reproductive coercion, like having their pill taken away or hidden, being stopped from accessing medical care to get an abortion, all those kinds of things. So they also experience, on top of that, forced or coerced abortion, forced or coerced sterilisation, excessive use of long-acting reversible contraceptives, and disregard for consent and decision-making. And we're going to go through each of those. Oops. All right, on to you, Tess.
Thanks. So I'm going to talk a little bit about sterilisation. So sterilisation without informed consent is actually against human rights, and it's restricted but not illegal in Australia, unfortunately. It's a form of violence and control over women with disabilities, and it's often targeted at women with intellectual disabilities. It's also a misguided attempt to manage menstruation and prevent pregnancy in cases of sexual violence, where we should actually be educating women with disabilities instead of doing this. So historically, this was hidden from women with disabilities, and today women are often taken overseas by family members, or they find a specialist who will hide the true nature or reason for the surgery, whether that be involuntary or coerced sterilisation for people with disabilities. And I'll just read a little quote from Stella Young. Keeping in mind Stella Young died at 32, and this was happened when she was only 3 or 4. And it says, as he was preparing to set my leg, the doctor turned to my parents and said, we may as well go ahead with the hysterectomy while she's still here, reveals Young. It was just assumed that for a girl like me, sterilisation was a logical choice. And I guess this speaks to the fact that these kinds of ideas and practices are still very prevalent today. And yeah. So also, sterilisation is often the complete hysterectomy for women with disabilities, and this often is the removal of the uterus, and it's not the less invasive kind. It's like sterilisation of blocking or removing the fallopian tubes, and it's very hidden in the data, and it's currently not gathered. So most of this information comes from the Centre of Inquiry into the Involuntary and Coerced Sterilisation of People with Disabilities in Australia. And Zoe has another wonderful example to share.
Yeah, so an example from recently that was shared with me by a woman with a disability was a woman who's a migrant and a person of colour. And when she went to receive prenatal care from a gynecologist, her doctor tried to convince her while she was pregnant with her first child to get a hysterectomy after she gave birth. And yes, she had a disability. It didn't, wasn't going to have a massive impact on her ability to care for a child. And she had a partner and she was well supported by her community. But it just shows that it's still, this happened in Melbourne, happened a couple of years ago. It's still a common experience for women with disability out there in the community. All right.
So are you reading the quote or am I reading the quote?
You're reading the quote.
Yeah. So, as a disabled woman to the outside world, my choice to end pregnancy was seen as unquestionably the right decision. This view potentially stems from fears around passing on genetic disorders, and it's a fear that has its origins deeply rooted in eugenics and what is subjectively deemed as whether or not a disabled person can live a good life, in quotations. Or it could have come from the unwittingly negative views that surround our bodies and our ability to adapt and cope with motherhood. And this quote comes from Nicole Lee, who is a disability and family violence advocate. And it's important to note that we all have similar experience to non-disabled women about coercion from the outside, but it's motivated by prejudice in the form of ableism, and women with disabilities have additional excessive scrutiny of our parenting ability, like nurses watching on new mothers when their child's first born or something like that. And parents and our family are often worried about the impact a child may have on them rather than our ability to parent well. And this prioritises the desires and opinions of non-disabled people above the rights and bodily autonomy of disabled women. Thanks, Zoe.
So this is our last slide before our break. So get excited, stay with us. So consent and decision making. So we kind of talked about this a little bit all the way through. But women with disabilities, when it gets down to it, are, able to make decisions about themselves and their bodies. Supported and informed decision making is obviously key, and it's really marked by a respect for bodily autonomy and this idea of dignity of risk. So dignity of risk is this idea where when you make a choice, it can have an impact, positive or negative, and you have to deal with the consequences. So that's a normal thing that we all do in life. We all make choices. And people with disability have the same right to make good and bad decisions. So there's this idea, especially around disability, of like trying to protect women with a disability, like they wrap them in cotton wool and nothing will ever go wrong. But it's having this dignity to make your own decisions, to live with the consequences. Everyone with a disability has that right too. So it's something to really keep in mind when people are making decisions, especially when you think that they might be not making the same decision that you would make, or that's the best decision. That's their choice. When it comes to decision making, it's about the individual, not family members or carers. Like, they might be in the room there to help support a woman with a disability, but it's not up to them. It's not their decision. And it's really important to consult directly with a woman with a disability. And there's also an assumption of competency to consent. So if you're interested in this, the Office of the Public Advocate has a lot of great resources about competency to consent, but we all work under the idea that someone can consent if they're in front of us, unless there's information to the contrary of that, like we know that there's a guardianship order in place or something like that. So we don't work under this idea that we're doing what's best for the person, because what's best is different for every person. So there's always a competency to consent. Give women with disability the information and time to make decisions that they need to make. They may not be able to make an informed decision in a very short, sharp consultation. That's okay to come back and make that decision. And as a professional, regardless, if you're in a clinical context, sure. If you're not in a clinical context, this is still applicable to you. The professionals must actively address power imbalances. So this is if you're in a room consulting with women with disabilities, if you are, facilitating education, in a variety of contexts. I, as a person without a disability, always have to check myself that I'm giving space, time, listening to women with disabilities, because I'm not the one who's representing that experience. And it's really important as a professional to take a step back and hand some of that power over. So giving people time, the space to make decisions and things like that, that's about shifting the power balance, right? And when we come back to power and privilege, that's part of that process. Excuse me. And something that's also important that lots of women with disability note is that, just like consent in sexual relationships, consent is a continuous process. So if you're doing a procedure, if you're doing something that's a multi-stage process, getting consent at every stage is really, really important, because like that little quote that we have there on the slide says, let's go at your own pace, let me know when it's okay to continue. That's really powerful, to give someone that choice, that they can say stop and you'll stop. That's just basic consent, right? And we all know this as a principle, but when we're talking about women with disability who have probably experienced discrimination and violence, it's really important that they know that they have some control in that situation, and that you're giving that power back to them to make decisions about how things are going to happen. And lots of women with disability note that this is an experience that they've had. And it's really, even just saying something as simple as that, let's go at your pace, is life-changing for them, because they've been rushed through systems their whole life. You might be the first person to say that to them. So this is just a quick introduction into accessibility. And I realized that I didn't quite answer some of the questions that were asked in the chat. So I'll just do that after the video. So settle in with your cup of tea that you just made, and
How to be more accessible in a hospital or clinical setting.
Ramps,
you got them.
elevators,
Ding ding.
accessible bathrooms.
Very flush.
So you have nailed accessibility. Phew. Yeah, no. Access is way more than those three things.
Accessible and inclusive language.
There are a few easy ways to make women with disabilities feel welcome wherever you are. Language and your actions are the most important.
Things like saying wheelchair bound. People aren't bound by their wheelchair. Mobility aids represent freedom.
Instead, say wheelchair user.
Avoid using slurs, ableist language, and alternative words for disability, such as the R word, spastic, crazy, lame, special, are completely unacceptable. Instead, use professional terminology such as disability, intellectual disability, or mental illness.
Reclaimed language such as crip and cripple is not for non-disabled people to use. This language has been reclaimed by disabled people from its derogatory origins and is now used to signify disabled pride, just like queer in the LGBTQIA+ community.
Avoid using terms like vulnerable or at risk to describe women with disabilities. This language is really disempowering and makes women with disabilities sound like they are powerless. In reality, women with disabilities are incredibly strong and adaptable. It's the people and society who are failing them. Instead, you can say women with disabilities are a priority, key, or primary population or group.
Don't correct the words people use to describe themselves. Use the words they use to describe themselves. If they say disabled, great. If they describe themselves as a woman with a disability, then also great. Disabled people are well aware of the power of language and will often make a purposeful choice in why they use those words to describe themselves. No need to correct them.
Consent and collaboration. Checking your assumptions at the door. Stop. Consent, collaborate, and listen.
So many women with disabilities have experienced trauma at the hands of medical providers and the medical system.
These can be things like overhearing a medical professional make a joke at their expense, or withholding of treatment for pain, or dismissing their condition as all in their head.
Through to non-consensual restraint, assault, or sexual assault. It is actually better to work with the understanding that women you see have experienced trauma rather than not.
This approach is called trauma-informed practice. It aims to avoid re-traumatizing, is non-judgmental, and understands that many problem behaviours are actually coping behaviours. A key way to do this is by maintaining bodily autonomy, which is basically the concept that your body is your own and you have a choice about how others treat you. Easy ways to do this is to ask before touching or talking about a sensitive topic, letting the person indicate yes when it's okay to start, and respecting them when they say stop or no. It's simply consent.
Next is collaboration.
Disabled women are experts in their own experience of their disability. So that means you have to work together on finding the best solution for them.
Don't assume that you know what's best. We have seen this a million times before. We've tried all the latest and greatest things out there, including yoga. So don't suggest yoga.
Just ask the question.
And listen to our answers. Like really listen, repeat back what we have told you. Give us time to give you a full answer to your question.
Leave your assumptions about women with disabilities at the door and be open to working together.
Talking taboo. This doesn't mean that starting the conversation will be easy, especially when it comes to taboo topics like sex and disability.
Remember, you hold the power as the professional in the room, and people are often waiting for you to start the conversation.
The best way to start is to ask permission.
Starting with, can I check in with you about the impact this might be having on your sex and relationships, is an easy way to open the topic.
You don't have to be an expert to start a conversation. Listening and holding space for others to share their stories is key.
Don't be afraid to refer on to other professionals. Sexual and reproductive health is a massive area. You don't need to know everything. This is my job and I don't know everything.
And finally, listen for disclosures of violence or abuse and follow up immediately. If you want to learn more about reproductive coercion and violence for women with disabilities, see our previous video. The link can be found in this video's description below.
Respecting the sexual and reproductive rights of women with disabilities is closer and even more practical than you thought possible. We are so close to the equity and justice women with disabilities need to feel safe and respected in health services.
Do you need a few more ideas on how to be more accessible? Before we finish up, here's 20 more tips on how to kickstart accessibility.
Advocate for inclusion and diversity.
Ask why there isn't a woman with a disability in the room.
Acknowledge the wider ableism in society and do your best not to replicate these ideas inside your organisation or home.
Represent women with disabilities in promotional and printed materials, not just women in wheelchairs or other kinds of physical disability.
Employ women with disabilities.
Represent women with disabilities in your data.
Make your communications accessible to women with disabilities. Have plain English and easy English available, image descriptions, web accessibility, large print, audio and braille options.
Represent women with disabilities in policy and advocacy.
Feature women with disabilities at events and make your events accessible.
Make connections with disabled persons organisations and disability service providers, or like us, Women with Disabilities Victoria.
Have a disability action plan and find out how it will be implemented.
Make sure women with disabilities are represented in management and in board appointments.
Consider physical access beyond the ramp at the front door.
Make sure your service is low cost. It's incredibly expensive to have a disability and not everyone is on the NDIS.
Make sure you have interpreters available and you know how to work with them, especially for Auslan.
Learn how to work with facilitated communication aids such as communication boards.
Planning accessibility from the beginning when designing and applying for funding.
Allow for additional time and don't rush.
Avoid using jargon or acronyms.
Acknowledge women with disabilities as experts in their own experience.
So what are you going to take away and start doing in work today?
We live forever on the internet now, so if you need a reminder, come back and visit us anytime you like.
Thanks for watching.
And we'll see you next time.
All right, so we are about to jump into our breakout groups. Oh, sorry, I was going to answer people's questions first. So, Heather, I think, said, I've heard that many women with intellectual disability don't need cervical screening because they aren't sexually active. Obviously making this assumption, assuming that that is the case, that they're not sexually active, is easily remedied by just asking them if they are. You know what they say about assuming makes an ass of you and me. So just don't assume that they don't need a cervical screening for that reason. Yeah, it is an assumption out there, is obviously not correct because you don't know if someone's having sex unless you ask them. Great, I hope that answered your question. So Johanna, our lovely support person, is going to break us into our breakout groups. I think by the look of things, we have about 44 people currently. So what we'll do is we're going to break into 4 groups, which will be obviously approximately 11 people per group. And you will find one of us in the groups. You will find Anne-Marie, Nissa, me, Zoe, or Tess, and we're going to have a question for you there that we're going to discuss. It's going to be about 15 minutes, and then we're going to come back and discuss the answers with everyone. I'm so glad that we got to cover everything though, so that's fantastic. Tess, do you want to take us through a recap?
Yeah, so today we covered disability and gender, we covered ableism, we covered sexual and reproductive healthcare rights, we covered power and decision making. We also covered sexual and reproductive healthcare topics like sterilisation, contraception and abortion. We covered inclusive approaches such as language and, well, we didn't cover trauma informed practice, but language. Yeah. We covered problem solving around common questions, and just to reflect, we can ask ourselves, what actions can I commit to increasing access for women with disabilities? What is one new idea that you encountered today, or did you have an aha moment? And I just remembered that in our in our breakout groups, somebody asked about like accreditation for doing this course, and like in terms of a, you know, like a rainbow tick in comparison. And I think while we don't have that available, we can provide you with certificates.
Yes, I haven't. Yeah, if you want a certificate, let me know.
Yeah, so I hope that answers the question precisely.
Great question. You know, if you still have time to hang around, if anyone wants to share one new idea that they encountered today, you can either pop it in the chat or an aha moment that you had. We love hearing those. If you don't want to do that, you can start filling out the feedback form, which is, the link is in the chat, and you'll also get emailed a link to that. So please fill that out, because we need the feedback for evaluation. So that would be great. Does anyone have anything that they'd like to share before we head off? Yep, I can. Oh, who? Yep, I can see that you've got your hand up. Go ahead.
Hi, I think it's me. Hi, I'm Sarah Whitburn. I'm a GP.
Hi,
and I work at Family Planning Victoria. So thank you so much. I've actually learned a lot to use in clinical practice, so thank you for the session. I have an interest in working with people during menopause and middle to later life, and I just wondered if you had any resources or pointers for people for reproductive health care and in that age group. When I was looking for information to support people with disability with menopause and later life sexuality, I couldn't find a lot of Australian resources, and I wondered if there was anywhere that you could help me find that for use in my clinical work.
Yeah, I mean, I'm sorry, I'm just reading the chat.
Yeah, the chat pops up, doesn't it?
Yeah, so yeah, unfortunately there's not a lot out there. I just put together a stories resource where there was a person in there that was reflecting on their experience around trying to access perimenopause services as a person with a disability. The story was unfortunately very negative. As far as I know, around resources in Australia, it's you know, Jean Hales is the go-to, but yeah, unfortunately there's not a lot around it.
Thanks for the chat, Estelle. Jean Hales has lots of fantastic later life sexuality, but I was looking to upskill and maybe a bit more information around disability. So in some ways, knowing that I haven't missed a great big resource is reassuring, but also, you know, obviously wanting to upskill and support people. Yes, of course. I mean, I think a lot of what you said today can be used in those spaces, and a lot of my sexual health skills I use in that space. But it definitely would, and you talk about sitting with discomfort as a clinician, sitting with the discomfort about how certain things happen and doctors speak is definitely uncomfortable for me. But I would be interested to know any, you know, that, as you said, that the resource you've put together, and really interested in you know, anything in the future and things like that, because obviously want to be supportive.
Yes, well, yeah, I'll definitely, if I ever find a resource, I'll send it through to you. But yeah, so we just released some new resources. So the video that you saw is part of a series of videos that covers basically all the content that we covered today, just a really, really short version. We also have a fact sheet about sexual and reproductive health and women's disability, and we also have a series of stories collected from women with disabilities around accessing sexual and reproductive health care and what that looks like for them, positive and negative. So that'll be a great resource, I think, in starting those conversations maybe within your workplaces around these experiences, and just a good way to, I guess, start some professional reflection as well, which is always, I'm a very big advocate of professional reflection. Yeah, so yes, I think what you're saying about menopause and disability is what is reflected in the literature overall. There's not a lot of literature from Australia. Disability is not very well represented in sexual and reproductive health. There's not a lot of data collected around it in any regular way. Disability isn't one of the boxes that gets ticked on cervical screening, for example, which makes it really hard to track, you know, how cervical screening is getting done, as we saw from that question before around intellectual disability and cervical screening. We know that it's a lot lower, that's for sure. So yeah, those are all things to keep in mind. So if you ever have a chance to collect some data, please collect the data. I need it. Other people need it. Please put it somewhere. I don't mind if it's not in an academic publication. Yeah, it's a real missing area in around disability and sexual and reproductive health. So yes, I would love some more data. But yes, thank you for coming along, and say hello to all our friends over there at Family Planning.
Thanks very much.
I might just jump into the chat. Carolyn said that her aha moment was love the quote that was the client leads the conversation where they're at. It's not for us to assume anything that is relevant for them. Great, fantastic. Yeah, I think that's it. So we might wrap up there. As always, we're always open to feedback. Please put feedback on the feedback form. Everything will be sent out from my email, so you can directly email me back. You can email Tess if you want to. Of course, if you need to, please do. Otherwise, thank you so much for coming. Thank you for braving lockdowns, ridiculous weather, and sticking with us through this. We've loved having you, and we'll catch you at the next training that we have. If you're interested in doing more training with us, sign up for our email newsletter. We always promote our training in there. If you want to, you can sign up on our website, wdv.org.au. We'll see you later. Have a great afternoon.